Good afternoon, Ian.
Hi, Ben. How are you?
How are you?
Good.
Thank you very much for catching up with me.
Yeah,
We've been saying that we're going to try and get together and have a little chat about a particular issue for some time.
Yes.
So we've finally just sat down to try and get something on film. So the particular issue that we wanted to try and discuss is that interface between the nursing staff and the medical staff, particularly at that high stress time when they're calling either a code or a MET call or even a patient review. And I guess we both feel that we've got some common ground to cover. And I feel like we see this recurrent situation cropping up in a lot of those wristbands maybe, or the clinical incident reviews that we do. So I guess that's in a nutshell why we wanted to catch up. Now, I think if we start to flesh that out a little bit, really the point of doing this is to really try and get across from me, from the medical side of things, what I want to know in that stressful situation where you've called a code. And I think, I'm speaking for you, but I feel that when there is an issue in that space, you empathise with the nursing staff, and you can see how they have maybe struggled to get information across or feel like they haven't been heard. So that's really what we wanted to discuss. So what I'm going to do is start by asking you, Ian, so when you read some of these wristbands and when you talk to your staff about the MET calls or their interactions with the doctors, what is it that you feel like you're hearing, or what is it that you feel like the medical staff could do better to, facilitate a better interaction?
So I think you've said that it's a stressful situation. So I think that's a key thing. So it is a stressful situation. It's not something our staff are dealing with all the time. And obviously we have different levels of staff as well. So there's that part. So your senior skill mix, and you've got your junior skill mix. So, and that always plays a key in it as well. So I think one of the things that I do hear is that, and you've mentioned, is that they aren't listening to me, or I didn't feel that they're listening to me, or part of that process felt it was more of a why have you called me? I don't want to be here. You can't tell me why they're here, why you've called me, that type of thing. So, and I guess it then creates that barrier. That I guess a level of, for some staff, a bit of intimidation. I mean, it's an emergency doctor, it's an emergency nurse coming, experienced people, and it's then expected that in that stressful situation they can roll off their tongue exactly what's actually happened to that patient right then and there. And so I think that's part of the main issue that's actually been occurring. As I said, not all the time. Sometimes we're giving lots of information, and then again it's just too much. So it's trying to streamline it so that we get our staff, not our staff, the nursing staff, comfortable, and to provide the information that the emergency doctors need to come and then have a treatment plan for this patient. So then we have great, we have good outcomes and everyone's happy.
And I think just listening to you speak, and again, when I read those reports, or whatever it is, I feel like I find myself empathising with the medical staff, because I know for me personally, when I arrive in that scenario, I find it, I won't say I find it intimidating, but I find it very stressful as well. And I think, I've come into a room that's not my normal environment where I'm used to practicing in the emergency department. I don't know what's going on. I don't know who the patient is. I don't know anything about the scenario. And I think just appreciating that I'm at a level of stress as well. So, and again, I speak for myself, I probably speak for the other emergency doctors. We just want to know what's going on. but in that stressful environment, when things are happening very quickly, we need that information very quickly. And I feel like, you know, I will have been guilty of it before, when somebody's telling me a rambling story, when I can see somebody deteriorating in front of me, or I'm like, no, we need to get to the point. I need to know this information. And I think when I listen to some of the stories and I can see both sides, and I can see that the nursing staff, they're super stressed and they don't know necessarily what I need to know, and I'm super stressed and I need certain information, and I think that's where that friction starts.
Yeah, and I think what we're finding also is that either we're giving too much, or not enough of the right information, and I guess that's. And it's experience, isn't it? So the more you do these, you have these acute situations such as met calls, codes, that type of thing, and you have to provide that information. Obviously, the better you get, and you can then identify the information that is needed directly right then and there. Where, if someone's come in, they've got a respiratory problem, you don't want to know that they had an operation 10 years ago for a fracture. And so then the nursing staff, if they don't have a lot of experience, and it's like, what do I need to? What history does the doctor need to then help and get things moving, and then they get a bit muddled up
and I know that, and we can all be guilty of that from time to time, and that's that whole. It takes years and years to be able to boil all that information down to be able to present the relevant bits in the right order for somebody else. And I guess that's why we tend to start, it's difficult, so we tend to start falling back on particular tools that we could use to try and structure that. And now, I guess the more common one that people talk about is the SBAR handover, or ISBAR, where you introduce yourself at the start. So I know that we try and, or we're going to try and teach people that, but I'm just wondering if you could sort of explain how that format works, and then we can sort of talk some more about that. So what do you understand by the SBAR?
So obviously the ones that we've been talking about is the ISBAR, so it's the introduction. And I think from a resource point of view, we've always talked about being that when the arrest team arrives, it's hi, I'm Ben, I'm Dr. Walters, or I'm Ben, I'm the ED doctor. How can I help you? And so trying to create that environment of welcoming. We're going to support, same as the nursing. So I'm Ian, I'm caring for the nurse caring for the patient. Obviously this is done very quickly, and so the idea being that ISBAR is the introduction, or you've got your situation, so therefore what's happened, which would be why I've called the Met call, or why there's a code blue, patient's having CPR, so looking at the situation, which is the key information that I believe the ED doctors need to know, and then obviously the background of the patient, and then that might be very succinct in the sense that you don't need all that other old history. It's what's relevant right now, where the patient's got the situation be the patient's increased shortness of breath. They came in with exacerbation of asthma. That's their background. Obviously, any assessment that has been done that's relevant to this current situation might be that we've done an ECG. And then obviously recommendation is the last letter, which for recommendation is I've called Met call.
So you're looking to me for a recommendation at that point, aren't you? So that's what it stands for. I think breaking that down now. So introduction, you've already described that, and we can see why that's important. But from my point of view in a resuscitation, a tiny introduction gives me an idea of who everybody is and what I can expect for them.
Exactly.
Because when you're creating that ad hoc resuscitation team, if somebody comes in through the door and says, I'm Dr. X, I'm the obstetrician, I know that I can't give them airway to do. But if they introduce themselves, I'm Dr. X, I'm the intensivist, then I'm thinking, okay, so I know what I can expect from them. And I guess that's the same with the nursing staff. I don't really know.
No.
I know lots of nurses in the hospital, but I don't really know, you know, who they are and what they can expect. So, and I think that's why that introduction is really important.
And I think, in saying that too, Ben, I think one of the key things, like with our advanced life support course that we run here at the hospital, one of the things that we teach the advanced life support nurses, so the nurse that would have been coming with you, is that they're going to manage that team. And I think it's so they're going to hear that information as well, so they understand, okay, who have I got already in the room, and who can I call on? You know, so obviously in caring for the patient, they're going to be able to provide more history, and then they can then run that. So I think. So another important aspect of potentially why.
And that's also important when we talk about other issues in the hospital with the codes, particularly when tons of people arrive and you need to start trimming down who's in the room. It's not that you don't want lots of help and you don't want people to see, but you can then start working out who's going to be useful for that team, who we don't need right at that moment in time, so you can trim out. Okay. So then the situation. And I think that's a lot of the key to where our difficulty lies. Because I would ask the question, why have you called a MET call? Okay, I probably won't point at you, but if I did, you could see why that would be intimidating. And so,
but I think as soon as why as well.
That's the word.
As soon as the doctor says why, if they're pointing or not pointing, that's the key word of...
you think I shouldn't have? And that's not that. No, that's not what we. That's not what I'm saying. No. It's just I need to know the aspect, the situation, and like so we talked about a case earlier of somebody who had pneumonia or something like that, and that point of escalation came when the patient's blood pressure dropped, so they had become hypotensive. So that's the situation, hey? So that I've called a MET call because this patient is hypotensive.
Yes, that's right.
And so I think that the doctors need to work on that, that their line of questioning maybe, or maybe the nurses need to work on how they present the situation. But I think we also need to be able to both empathise with one another in that moment. I need to think, this nurse is very stressed. She thinks I'm challenging her, why I've called it, but I'm very stressed. And I just need to know what I'm doing here so that I can get my head around what...
And then you can act.
And then I can act, and then I can get going with it. So I guess that's the that situation. And that situation can be different. You know, I'm concerned about this patient. And that's the difficult one, isn't it?
It is.
With the MET calls. Because then, and if you say that to me, I need you to tell me why.
That's right. And that's the thing, and that's probably the other side where we're getting a lot of that that feedback that we want staff to call a MET call, even if they're not meeting MET call criteria, if they're concerned. But it's then articulating to the MET team, not that I'm concerned, that situation is that I am concerned because of the patient's tachypnea, or they're increasing shortness of breath, that type of thing. And I guess that's what you want to know, not that I'm only called it because I'm concerned. It's like, okay, but what were you concerned about?
That's right.
There's got to be a reason that you're concerned.
But that question, and I can see how somebody who's stressed, who is genuinely concerned, or even if you can't put your finger on why you're concerned, when somebody is asked that question, it puts them under a lot of stress. And so my note to self is, you know, I don't know, I need to try and work out a different way to draw that out of somebody who can't express it. But also they need to think about what those specifics are of why they're concerned. Otherwise I'm going to struggle to help them. You know what I mean? So I guess that's one thing, and I think that's something that we need to try and work out a way to work on that interaction and how to vocalise that. But let's move to the B. So then the B is that the background to the situation, and like you said, sometimes people will tell you a whole story about, okay, they're 68 years old, which I do need to know. You need to know the age. The age is good, but it's, you know, they've been in hospital for 3 weeks. They've had this, they've had that, they've had this. They've got a cat, they've got a dog. They live. You know what I mean? And
I mean, they're all important things.
They are all important things.
Not in a met call situation.
But maybe later on.
Yeah.
So, and that's the bit that's super difficult to try and boil down and try and get, you know, which bits are the most relevant in that scenario. Yeah. So I think from my point of view, I guess, and that's sometimes why having the old chart is really helpful, not because they're going to read through it all now, but when I've got time, I will then always have to revisit it. And often when you go to a met call, we're having to send somebody to get the old chart.
Yeah.
Well, maybe that's just something that could just be brought so that I can start doing my research when I get a moment to do it.
And we do see that. Yeah. Where if you get that initial situation, you can start acting and start saying, okay, let's start doing this treatment. Yeah. Things are starting to maybe not settle, but you know, under control. Yeah. You've got the ALS nurse, you've got the other stuff. They're all working together and they're starting to do all these things. That gives you a little bit more time to okay, let's start thinking a little bit more about how we got to this stage, and therefore you may need those.
Because that bit, I can tell you now, is really extraordinarily difficult. Yeah. That being able to start doing, particularly if I've got to physically do something, and I've also got to instruct other people to do other things, and I've also got to start thinking about why it's happened and trying to piece the jigsaw puzzle together. When I'm stressed, you don't have the cognitive bandwidth to do all of that lot. So that's the super difficult bit. But I think that, so we've introduced ourselves, we've told the situation, this patient is hypotensive. And, you know, there might be some more to that, and they seem a bit more drowsy than they were previously, whatever. We can all imagine a picture where this would sort of fit in. Yeah. And then what is the background to that? I think that, I guess, without having necessarily a specific case and being able to have an answer to everything in one go, I think sort of the reason that they've been brought to the hospital and what it is that we think that we're treating, or maybe if they've recently had a procedure, or, you know, what's been going. And so what's been going on in the very immediate past, I think that really contextualises, you know, I guess, how the situation could be concerning. Yeah. And then there might be some relevant bits of the past medical history that, you know, that you should maybe throw in at that point, or there might be particular medicines that they're on. Particularly, I guess, if you imagine somebody, okay, this patient is hypotensive, that's the situation. Yeah. Background is they've had an operation recently, and they've just been started back on their blood thinning medications. You see how that becomes that super relevant background, and you don't probably need to know about all the rest of the medications, because. So I guess that they're the pieces that we're trying to sort of pull together, maybe. Yeah. That's the bit that's difficult, though, isn't it? Trying to pull out of those really relevant bits of information.
And again, you know, experience. Yeah. You know, experience with these situations, experience in your career. It pulls all that together. But that's, you know, learning off each other, and you know, things such as this to say, well, these are the things we're looking for. Yeah.
But I guess, from my point of view, and again, I feel this when we're teaching them, trying to teach the medical students, practicing this, you know, in your mind, when you're handing over a patient, and the nursing staff do that every shift, don't they? They hand over to each other, having to think through what's actually going on with the patient, and what is the relevant information particular to this patient that you would feel that you would need to know. Yeah. And so going through that mental practice every time you hand over a patient, I think that's probably a way that we can practice getting that information across.
And I think I mean, the nurses have also contact the VMO as well, and in situations where they need them to make an assessment of the information that we're providing them without actually visualising. They might know the patient, but they can't see him at a particular time, and they might have seen him yesterday, and it's been 12 hours. And then, and as you know, anything can happen in 12 hours. So therefore, again, providing that succinct handover using a tool such as ISPA.
Exactly.
To then say, this is the situation. This, Mrs. Jones is hypertensive. 95 on such and such. And I mean, ideally they should know the background, but there might be something else that's also occurred that they're not aware of.
So you're right. That's
more practice.
Once you start using that format, and you start practicing that format, then I think it becomes easier.
Well, it's like a second nature in the sense of, okay, I know exactly what they want. In this situation.
So we've got through the ISB and then assessment. So in some ways that's a bit easier because
it depends on the situation. Be that Met call, calling the specialist, the VMO, or is it just a standard handover from shift to shift? Obviously, in a Met call situation, the assessment is going to be probably less information available. Because the idea is that I'm telling you in the situation what the problem is. It's hypertensive patients. Therefore, the assessment was I did their blood pressure. It was low. That's why I called a Met call. Whereas I might chuck in things. Oh, we've already done an ECG or
But again, doing those things, they're all relevant, aren't they? Because in that moment of your assessment, you found that they're hypotensive. Usually you'd have done some other observations at the same time. And I'm interested in those observations at the same time. And again, the situation will depend on what other bits of the assessment you will have had time to do at that stage. And sometimes your assessment may just be that the patient is extremely pale and they look normal before and they're hypotensive. And all of those bits of the assessment fit in together. So I guess maybe that bit's, in my mind, that could be an easier bit of the SBAR, and the A bit might be the easy bit. And then the R stands for we have to remember what it stands for.
Recommendation.
I can't usually spell very well, but Ian knows this. So the recommendation, and that's, again, it sort of depends, doesn't it, on the situation. And I think what we were discussing earlier, you were saying that you felt you don't necessarily always have a recommendation as the nurse when you're calling this thing, because you don't necessarily know what's going on. And sometimes you're looking to me to provide a recommendation for the treatment strategy from there on. But I think it is important though, because I think sometimes with those Met calls or those calls for help where you have a concern, sometimes the nurses will have a recommendation. They'll have an action that they really think that needs to happen. And sometimes they won't necessarily say that. Or sometimes they'll say that and they won't feel that it's heard. But I think clearly articulating that is the first part of the puzzle, isn't it? And you might be, okay, they're hypotensive, they're this, that and the other, this is a case of sepsis. My recommendation is that they might need to be cared for in ICU, for example. Well, that's reasonable. Or the recommendation is, I think we need to assess the patient and then call the VMO to give them an update, and maybe we need to change either the place that they're being cared for or the treatment regime or something like that. I don't know, I'm just...
No, and I think that the thing though, I guess, about the tool, so particularly ISPA and any of those type of tools, is they're designed it's not just a nursing handover tool. It's for all positions. So be that, ideally if they're saying even, medical staff handing over to other medical staff, allied health, that type of stuff, they're all utilising the same sort of tool. So therefore, obviously, particularly if you're handing over or talking to a specialist, say I've seen your patient, you run through this part, and then you get to the recommendation part. what I would recommend is, going to do an X-ray and
yeah,
fluids, and I recommend them being assessed by ICU to get them in ICU for further treatment, because it's not appropriate to maintain that patient on the ward, in a ward environment.
Yeah.
So I guess there's that sort of side of it as well.
And I think in you saying that, I think that's definitely something that we as the medical staff need to practice as well. And I don't think we should be doing this with a view to try and get the nursing staff to be better at SBAR. I think we need to be better. I know that I'm definitely guilty of wanting to tell people too much stuff, and I feel that I need to hand over things thoroughly. A medical handover should be quite thorough, but there are lots of contexts where I can feel the person on the end of the phone has just nodded off to sleep because I'm saying too much stuff. So I feel I could be better at that. But also, when we're calling the VMOs, as you say, they're looking for a recommendation from us because we're their eyes. They can tell you what they would do, but they can't see the patient, and so we need to be able to be informing them what we're seeing and what we recommend that we do, or be very specific about what questions we have for them. You know what I mean? Like if I'm saying, I know what to do, I know how to manage this patient, but do you want me to use X drug or Y drug, or are you going to be happy to continue this management on the ward? Will you be able to see them in the next couple of hours, or you know what I mean? So I think we need to practice being specific about what our recommendations are to the specialists as well.
And I think you made a good point just a little while ago where you talked about providing that too much information, and I think people nodding off on the other side. And I think the really good point about that also is that yes, at times it is important to give that information. But then there's you got to pick those times. Obviously, met calls, particularly those high end, got to move quickly. We can mask things, can't we? Like what's really happening in all that information. And putting everybody at risk that you're going to miss it. And so I guess that's another reason why, particularly, the ED doctors need to have that succinct information, not clouded by all that extra stuff that this is important. And it's important to the care of the patient, but the long term care, not the immediate issue that's going on right then.
And I agree with that. That's the point at which I get frustrated in my mind when I'm hearing and I'm listening to this whole story, and we're getting to about a minute or 2 minutes of this stuff, and nobody's told me what's wrong. Why am I here? And that's the bit where that's the bit where I start getting frustrated, because I don't know that's all nice, but I don't know how to contextualize that. That's the bit where I get frustrated.
And the nurses think they've told you, because they have,
but they've told me a load of other stuff as well.
So I think that's an important part as well.
So Ian, I'm conscious that we've taken up a bit of time talking about this so far, okay? And I think that what we need to do now is, I guess in summary, we feel that the ISBAR handover technique is something that we need to try and work on adopting, and we need to practice doing this in our practice. And we also need to just both acknowledge that each other are under stress at that time. And when we start empathizing the situation that the other person is in, sometimes we can come up with our own solutions how to solve that. And I think the other thing that might be helpful that we could go on from this is to maybe get some case examples that we can do maybe even do some role plays of good versions and bad versions, that then people can consider how they would do it, and which bits they found were useful, and which things they found unhelpful. And so we can move forward. Does that sound all right? Excellent. All right. Well, thank you very much for taking the time to have a chat with me, Ian.
No problem. Thanks for having me here today, Ben.
It was a lot of fun.